members in our family, and education of the head of the family is that is the husband is high school. Um, Occupation of the husband is shopkeeper. Their monthly income is around 5,000 rupees, and she comes under modified Kupaswamy score of 19, which is upper middle class. Coming to the general examination, patient was made comfortable by explaining the procedure. A verbal consent was taken. Examination was done in a well illuminated room with adequate illumination, adequate privacy, and in presence of a female staff. General condition was good. KPS was 90. TPR, BP were within normal limits. There was no pallor, icterus, cyanosis, or clubbing. There was no pedal edema, and there was no palpable lymphadenopathy. Coming to the systemic examination, CNS conscious oriented to time, place, and person, higher motor functions were intact, and cerebellar signs were absent. CVS, S1, S2 heard, no murmurs heard. Respiratory system, bilateral air entry is equal. Per abdomen was soft, non-tender, and there was no palpable organomegaly. Bilateral breasts were anything. Coming to local examination on inspection, mons pubis, labia majora, minora, anterior and posterior fossette, clitoris, urethral meatus, anal virgin, perineal skin appeared normal. There was no visible or palpable inguinal nodes, no evidence of PV discharge or bleeding per vaginum. So this is the image of external genitalia. So we look for the any swelling or any signs of bleeding or discharge on inspection. Then we come to the post speculum examination. So we use generally use a Cusco's bivalve self-retaining speculum, which is adequately lubricated with lignocaine jelly before examination. The findings were cervix was enlarged and showed a ulceroproliferative growth of about 3 centimeter, involving both the lips, reaching the outer edge of the ectocervix in both the lips, and which was not extending to the vagina. So a Lugol's iodine examination was done, and there was no Lugol's negative area that was found in the cervix. So this is the Cusco's bivalve self-retaining speculum, and this is how we inserted in the patient. On per vaginal examination, there was a 2.5 into 3 centimeter ulceroproliferative lesion involving both lips of cervix. Anterior and left lateral fornix were involved. Rest fornices were free, and vaginal mucosa was free. Bilateral para was free, and rectal mucosa was also free. So what we usually do in a per vaginal examination is one hand is kept on the pelvic region or the abdomen, and we usually do a bi-digital examination on OPD basis. So this is an example of bi-digital examination which is shown in this image. This is the clinical diagram after examination which we draw in the OPD, showing the involvement by the disease. So as in this case, the disease involves both lips of cervix and the anterior fornix is involved. Posterior fornix is free. Also, the left lateral fornix is involved and the right lateral is free. Uh, so investigations will be discussed by Dr. Pranav.
The basic investigations were done for the patient. One was a routine blood investigation. She had a hemoglobin of 10, a total leukocyte count of 6.4. Her coag profiles were normal, and creatinine level was also normal. On a CT tab, 2.2 into 2.1 into 2.4 centimeter lesion was seen in the cervix, with maintained fat planes with the urinary bladder anteriorly and rectum posteriorly. On the MRI, 2.4 into 2.3 into 2.2 centimeter endophytic endocervical lesion was seen, which is reaching up to the internal os. Uterine body was free for vaginal fornices maintained and para not involved. No hydroureter and no lymph nodes were seen. So these were the images of the MRI. This is the T2 axial. You can see that the lesion is within the cervical region, and it's not breaching. This is the sagittal image of the patient. Next, we go ahead with the biopsy and HBR. Punch biopsy was taken, and HBR was not.
Pranav, Dr. Prachi here. Can I interrupt you? Uh, can we go back to the previous slide
Yes,
and the previous?
yes, ma'am.
Yeah, so in all patients, would you recommend doing CECT, TAP, and MRI abdomen and the pelvis?
Ma'am, according to the guidelines, we have to do a CCT, abdomen pelvis, MRI abdomen pelvis, and X-ray chest, ma'am. But since it is since we are in TMH, we follow that we even take a CT of the thorax also.
Yeah, so when you're presenting, you're not supposed to say what is in TMH or outside, and it is what is the optimal investigation and what is adequate investigations, right?
Yes, ma'am.
For early cervical cancers, what would be the gold standard for evaluation of whether a patient needs to undergo further treatment by surgery or radiation? Which investigation would you prefer? If a patient comes to you first time, what investigation would you do?
MRI, MRI, ma'am, and um, examination, ma'am,
Yes.
by manual examination.
Yeah, so FIGO 2018 states that that investigation is required for evaluation of cervical cancer, unlike the previous stagings where we were doing it more on clinical examination and based on ultrasound or chest X-ray. And our National Cancer Grade India guidelines state that we should have minimum of CECT done for patients, thorax, abdomen, and pelvis. And if there are optimal resources in India, we would prefer to do an MRI of the pelvis.
Yes.
Yeah,
Thank
please
you.
go ahead.
So, my question to you is the students, why is say that CECT is important? It should be done. What will you miss if CECT is not done? And what will you miss if MRI is not done? Or you may miss.
So we do a CGCT for the involvement of lymph nodes, and MRI is done for the local extent of the disease.
So if you do not do a CECT, you may miss patients
Miss
who
the
have gross lymphadenopathy. Okay.
yes, sir.
Because
Yes, sir.
ultrasound has limited sensitivity. It is not in the neck. We are talking of the pelvis and abdomen. So that is very important. And MRI, how does MRI complement the CECT?
For local infiltration of the disease to check for the local infiltration.
I think later on you will discuss how the MRI looks and which sequences will look. That you all have in the slide, no? Subsequently.
Yes.
Okay.
Yes, sir.
Okay. Carry on.
And then punch biopsy was taken, moderately differentiated squamous cell carcinoma. It is HPV associated and P16 positive. So the impression is a CA cervix, moderately differentiated SEC P16 positive, FIGO stage 1B2. The plan was radical hysterectomy with bilateral saprophorectomy plus bilateral pelvic lymph node dissection. Now, we just want to quickly go through the anatomy, supports blood supply, and the lymphatic drainage for the female entity. So
Hello,
this is yes,
doctor. Yeah, can I just interrupt? I'm Dr. Sneha, surgical oncology.
yes.
So, are we going to discuss these MRI films that you had put up on the
Yes,
previous slides anytime in the future, or are these the only? Is this the only slide with the films?
I think for
this
this
is
patient, this may be the only slide. So we can ask them, quiz them on these. What do you see there? Yeah. Yes, Neha, please go ahead. This is Dr. Sareen.
Yes, sir. Good morning, sir.
Good morning.
Sorry, I didn't get your name. Pranav, right?
yes, sir. Yes, ma'am.
Okay. So here, can you describe the image on that I see on the left on my screen? What
Yes,
is
ma'am.
that? What is the hyperlucent rim, crescent-like rim that you see there? What is that in the center? And what is seen above that?
Above that is the cervix, ma'am.
Yes,
And then below that is the rectovaginal pouch.
that is actually part of the posterior fornix with the vaginal jelly.
Yes. Okay.
And to the right of my screen, what are the important structures that we are seeing in the center?
Ma'am,
Can you
that's
point out at the cervix and the parametrium?
yes.
Ma'am, this is the cervix and this is the parametrium.
Yes. And very nicely, you can also appreciate the stromal ring here
Yes, ma'am.
around the cervix. So can we go to the next images?
Yes, ma'am.
So first, when you're always describing an MRI, you should tell that this is a axial
This is an
T, how,
axial T2, ma'am. Axial
yeah,
T2 images. Yes.
axial T2 weighted image of the pelvis.
Yes, ma'am.
Next image.
This is the coronal image of the pelvic region, ma'am. This is the cervix and involved cervix, and this is the these are the stromal ring, ma'am, and this is the parametrium on either side.
Right. And the stromal ring is intact, as you had
Yes, ma'am.
told in your reporting. Next
Yes, ma'am.
pictures.
This is a T1 contrast image, ma'am. Here we can clearly
Is
see
it
the
T1 or T2?
this is T1 contrast.
So
T2
the
flare. Yes, ma'am.
yeah, this is
So
T2.
T2
And
flare.
what is the very easy way to tell whether it is T1 or
Water
T2?
is water is white.
Water is white, exactly. Urine is white, right?
And this is the stromal ring which is preserved, and on either side you can see the parametrium, the jelly which is present. And then this is the sagittal image T2 weighted image of the pelvis. You can see the disease which is involving the cervix, the hyperintense lesion, and this is the walls of the vagina, and this is the cervical ring. So,
Yeah, one very important reason why do we put vaginal jelly inside a case of CA cervix MRI? When we do an MRI for CA cervix, we always put vaginal jelly inside. Any idea why?
um, uh, so as to separate the walls of the vagina and delineate the disease better.
Yeah, exactly. So the vagina distends, and that way we can exactly make out whether there is vaginal involvement or no. Though MRI is a little inferior to know to tell us the exact vaginal involvement, application of a vaginal jelly helps us to do this.
Yes.
We can proceed.
Yes. So this is a basic anatomy of uterus, uterus, cervix, and the vagina. You can appreciate the parts of the uterus, cervix, and then when we come to the supports, this is one a very important part. The supports of the uterus, they are divided into primary and secondary supports. You have the active or the muscular supports, which is a pelvic diaphragm, perineal body, urogenital diaphragm, and the visceral, which is the urinary bladder, vagina, uterine axis. The fibromuscular supports being the Mechandrods, pubocervical ligaments, uterosacral ligaments, and the round ligaments. The secondary supports are the peritoneal folds and the other rectovaginal pouches. Rectovaginal pouch, your vesico-uterine fold of the peritoneum. These are not active supports of the uterus. Next is the blood supply. So the uterus and the cervix are supplied by the internal iliac artery through the uterine artery and the vaginal artery. And the lower part of the vagina is supplied by the internal pudendal artery. The ovaries and the tubal areas are supplied by the direct branch of the aortic artery. All these have anastomosis in them, whereas the venous, you can see the uterine vein, vaginal vein, and the uterine venous plexus, which ultimately drain into the inferior vena cava. This is the lymphatic drainage for the cervix. most normally the cervix drains into the internal iliac, the external iliac, obturator, first obturator, the internal iliac, external iliac, parametrium, and goes into the presacral, and also goes into the presacral. What is the epidemiology? You can see that cervical cancer is the is the second most common cancer affecting women in India, with about 17.7% of the patients being involved, 17.7% of the population being involved. And then most common cause being the HPV infection. So HPV is a double-stranded DNA, various subtypes present. You can see it on the right side of the screen. Those are the various subtypes of HPV viruses. The most common being, most common involving the cervical cancers are the 16 and 18. There are various other subtypes. Less than 15% causes persistent infections, and majority are cleared within 2 years of infection. So the progression from the infective stage to the cervical cancer stage takes about 10 to 20 years. And on the right hand lower side, you can actually see how the HPV progresses into HPV infection progresses into a cancer, also into cervical cancer, by producing the required proteins, which is the HPV E6 and the E7. So this is how the natural history of for cervical cancer progresses. One is the exposure. One is from we start from the exposure related causes being multiple sex partners, early sexual debut, high parity, no circumcision. You get your HPV infection, you're infected, and then you have susceptibility related causes, which being high risk HPV infection, weak immune responses, and other STDs. You have genetic predispositions to. And then you have micro environment, which are multiple HPV infections, smoking, long-term use of oral contraceptives. Then genetic and epigenetic being HPV integration, that is your E6, E7 proteins acting oncogenes expression, which later leads to production of your virus integration and production of the viral genome within the cervix. All this takes about 10 to 20 years, and almost 85 to 90% of the people infected with HPV revert back, whereas revert to non-HPV status, but about 15% progress to getting a cervical cancer. So this is how the HPV infection, earlier
Let's go
slide
back.
I showed. Yes.
Yeah, okay. Okay. So you are showing this slide. So from where do we get this information about the natural history of cervical neoplasia? Okay, from in situ to invasive carcinoma. That is one question. Second is, from where have you taken this slide? You should always acknowledge the credit the source. You have not made it, isn't it?
Yes, sir.
So
Yes, sir.
so you should
Uh,
always, it is a good habit. Whenever you take someone's hard work they would have put in, you always acknowledge the source. It may be a textbook, it may be a journal article, or you may have also made it. Okay, so you should always do that. Third is, you talked about the risk factors. What are the protective factors? Okay, so answer my question. So from, first of all, from where have you taken this slide, which sort of captures everything? How do we know that this is a natural history of untreated cervical neoplasia? And third is, what are the protective factors?
Sir, this slide was taken from um, he was a he's a medical student, sir. He posts these slides on online, so I just took it from there.
You should get
I
it. And that medical student may have taken from somewhere else. So so we do not know.
yes.
So always in science and medicine, we should know what we are dealing with. Is it authentic or not? Something. Okay. So now, where does this knowledge? Was there some
Yes.
study, prospective study through that or something else? How did we know about it in the first place?
Yes, sir. Mm. No, sir.
Do you have any idea since how long, how many years cervical cancer screening programs have been going on in some countries? 10 years, 20 years, 30 years, 40
Sir,
years, 50
it,
years?
around 1980s, they have started
Started
cancer.
what and how? You know,
Yes.
see, cervical cancer, much before HPV was known, there was already a lot of screening programs in cervical cancer. So a lot was known. Cytology was already established. The screening was already on. So you should know that it doesn't mean that before HPV was known that we did not know much about cervical cancer and its screening and prevention. Okay.
Yeah. Yes, sir.
So what are the protective factors? Now you told about the risk factors.
Um,
The strongest protective factor for cervical cancer, the strongest.
Sir, HPV vaccination, sir.
Yeah, HPV vaccination. And then what else?
So use of barrier methods for intercourse during intercourse.
Okay. Is there anything else,
Sir,
Prachi,
circumcision.
or
So,
circumcision? Yes, that's important. At the age, at the very infancy, like in the age of circumcision in Jews is almost newborn, and Muslims it is later, not in a newborn. Absolutely. So, and how does circumcision help? So, how does circumcision is related to cervical cancer or penile cancer? Why should circumcision affect cervical cancer
hygiene,
risk or penile?
hygiene, probably hygiene is the cause leading to reduced HPV infection in
Anything
case of
else you all know?
circumcision.
We don't have time in a cervical cancer, topic, but you all should know what are the theories why circumcision can help. Okay, carry
Yes.
on.
So this is how the HPV infection progresses to a cervical cancer. You can see how it integrates into the basal cells of the cervix, how it integrates via different proteins which are produced by the HPV genome, and how further it leads to tumor silencing tumor suppressor gene, and further providing immortality to the cells. Now, this is
I
spread of.
just want to add in one thing with respect to the prevention of cervical cancer. What all we discussed till now were the methods of primary prevention of cervical cancer, all the HPV vaccination and circumcision and hygiene and all that thing. But there is also very importantly secondary prevention of cervical cancer, isn't it? Screening.
Yes, sir.
Screening.
Yeah. Screening is one of the very important methods of prevention of cervical cancer. And that is what India heavily relies on, because we do not have a national immunization program for HPV vaccination as of yet. So we should always mention screening.
Yes.
So when we talk of prevention, always talk about primary and secondary prevention and early detection. I think you all have slides for that later on. No,
Yes, ma'am.
you
Yes.
don't have.
Yes, sir. Yes, sir.
Yeah, they have slides. Okay.
So this is a paper by Fabio Landoni for the spread of cervical cancer, which is a local spread in which 230 patients were treated with radical hysterectomy. It was found that they are equal. The tumor spreads equally in all directions. So anterior para, the vesical cervical ligament was involved in 23%. The posterior para and the rectovaginal sac was involved in 15%. Parametrium 28 to 34% was found in the study.
Pranav,
So,
please go back.
yes, ma'am.
What is the heading of the paper and what are you talking?
Ma'am, it is a randomized study of radical surgery versus radiotherapy for stage 1B, 2A, ma'am. But in this paper is again being discussed later, ma'am, uh, during the management of cervix, ma'am. So this is only to show how how the cervical cancer has a local spread, ma'am.
So
So when
this,
you're presenting this, you should say like that. From this randomized trial, there's also information regarding the spread of cervical cancer because they're surgical, they're radical hysterectomies. Okay, so you say like that. You should not say that. Okay.
sir, I think there would be two different papers because in this study, around 170 odd patients underwent surgery.
Yeah,
So,
yeah.
yeah.
So this is, I think there must be some follow-up study or the larger number. So
Yes,
just
sir.
because
It
the
was
landed name is common doesn't mean you can just.
Yeah. Yeah.
So this again, you have taken this slide from some other student, or how is it?
No, ma'am, no, sir. I went through this paper, sir. I have the paper, sir.
So in the paper, this paper only they have 230 patients. So because what Prachi is telling, I also remember similar number for the
So,
randomized trial. Anyway,
so
carry
actually,
on.
340 patients were selected, sir, of which 230 patients were of 1B, 2A cervical cancer types,
Okay.
and those which
Okay.
underwent
Okay.
radical
You may be,
hysterectomy.
you may be right. I don't recall that. Okay, carry on.
This is another paper by the importance of parametrial lymph nodes in treatment of cervical cancer by Frank Girardi. It has shown the involvement of parametrial nodes in 359 patients who have undergone radical hysterectomy. They have found that the parametrial nodes were involved in 78% of the patients. One in and the pelvic nodes and post histological examination, the pelvic nodes were found to be 81%. So the 78% which they were is at the time of surgery, and the para and where 22% were negative parametrial nodes, but on histological examination, what they found was the pelvic nodes involvement was about 26% on histological examination. Uh, so in this shows the percentage and how the lymph nodes are being involved in the pelvic region and in cervical cancer. So the distribution of pelvic lymph node mets. By this paper was by sorry, this paper showed, sorry, this image shows the involvement of the the different lymph nodes being involved. And then the different author doctor by Lagasse et al. And Wharton et al. You can see the percentage of paraiotic lymph nodes being involved in early stage cancers being uh, uh, these are the percentages being involved. So, what are the distant metastatic sites in the first distant metastatic sites? Being lung being these are generally hematogenous spreads, being lung being 21%, abdominal cavity being 8, supraclavicular lymph nodes being 7%, spine 7, GI 4%, liver being around 4%, and then you have lymph nodal involvement being 11%. Inguinal lymph nodes generally are rarely involved, but then if at all lower vaginal lymph involvement, if there is a lower vaginal involvement, it can go into the inguinal lymph nodal region.
You're talking
So
of early stage cervical cancer. That is not really relevant for them.
yes,
Okay.
this
So,
is not.
and unless until you tell us what is the distant metastasis rate in early stage cervical cancer. Okay. If you don't say that, this is not really relevant. Okay. Go to the next slide. Yeah.
So these are the symptoms of the clinical features with how these patients are present to us when
So in
we
the
disease
long list of
symptoms.
symptoms for early stage cervical cancer, what are the most common symptoms? Early stage.
Postcoital postcoital bleed or malodorous discharges might be the most common symptoms they might present us with. maybe menorrhagia and metrorrhagia, but those are quite rare.
Rare?
Not rare.
Are these rare symptoms?
Not rare, sir. They don't. Early cervical
Okay.
cancer is.
Okay. Okay. So rest of the thing you're describing is for. So I think today we'll focus on early stage cervical cancer, and the subsequent round we will discuss, locally advanced or cervical cancer. Next.
In
Yeah, you can go
cervical.
to the next slide. Yeah. Yeah.
So this is cervical cancer screening, and according to the ACOG guideline recommendations, we generally start screening at around the age of 21 years. PAP test alone for every 3 years. Then from 30 to 65 years,
Sorry
we
to
can
interrupt.
yes.
Have you also put the FOXI recommendations of cervical cancer screening?
No, no.
FOXI is the Indian committee. So India also has its recommendations for cervical cancer screening. And India recommends screening at the age of 25. And I think that is more important for our in our context.
Yes,
But you
ma'am.
can proceed whatever you have here.
Okay, then you can add HPV test PAP alone every 3 years, or HPV test alone every 5 years, and co-test every 5 years. And when do we stop it? When the patient is more than 65 years, and the consecutive 3 negative PAP tests, or two negative HPV tests, or two negative co-tests. So co-test is either an HPV test with a PAP test, or any other screening modality like your liquid cytology, etc. And there is no CIN 2 or 3. Now, these are the cervical cancer screening techniques, different modalities in which we can screen them. The next is in case the first smear is abnormal, or if there
Sorry,
is.
do you know of any randomized trial done in India of other alternative methods where Tata Hospital did that? Are you
Yes.
aware? So are you going to tell about that since you're talking about
Yes, sir.
screening? Okay,
We have
you carry
a randomized. Yes.
You carry on, then you follow up this thing because I have not seen your slides. You carry on.
The abnormal. So if there is an abnormal first smear, if there is abnormal smear or ascus, then the HPV test, if it is negative, and if there is ascus positive, then it go for colposcopy. Whereas if there is a positive HPV test, colposcopy, biopsy, or endocervical curettage is done. Biopsy, if it is negative, we repeat after around 6 months. Whereas if it is positive biopsy, we go ahead with conization. If it is SIL or adenocarcinoma in situ, we directly go ahead with a colposcopic biopsy. So now, if it is an LSIL, the age being more than 30 years, the HPV status is positive, we can go ahead with colposcopy. Whereas if it is negative, we follow up in 1 year with a repeat pap smear. If the patient is of the age between 21 to 24 years, we do a repeat cytology at 1 year. And if it is from 25 to 29 years, we go for a cytology it's based on the cytology of the patient. Now, the procedure for pap smear. Pap smear is taken from the ectocervix and the ectocervix and endocervix. So, for the ectocervix we use an IR spatula, and for the endocervix we use a cyto brush. The scraping is taken all around with the including the vault of the vagina, and the post and even the vault of the vagina, and all the fornices are also taken in. If the CIN 2 or 3, we repeat the test after 2 weeks, and annual screening will be done for the next 20 years. The precautions we must take is there should be no douching prior to pap smear, no use of lubricants, scrapings to be taken without blood. Now, these are the visual procedures of uh, using VIA and villi. VIA is using the acetic acid which is applied onto the cervix, and aceto-white areas are suggestive of disease. So, a TMH trial, it is a randomized control trial. Almost 75,000 women were screened every 2 years. There was a 31% reduction in mortality in the screening group. So it's useful for places which are lacking PAP screening. Another test is the Schiller's or the villi or the Lugol's with Lugol's iodine. Here the stains. Yeah. So after applying the area which doesn't or contain the area which is involved has less amount of glycogen in them, leading to a mahogany or yellowish stain being formed, which is indicative of the disease involvement. So
Yeah,
what is
you
the
explained about the reason behind the lack of Lugol's iodine uptake. Can you explain the reason behind aceto whitening?
Ma'am, in case of dysplastic or abnormal areas, acetohyte areas are stained due to increase in nucleus to cytoplasm ratio and the biochemical changes in the tumor, like dehydration and coagulation of the cells.
Okay, so the dysplastic cells, which are
Yes, ma'am.
rapidly dividing, have more amount of nucleic acid material in
Nucleic
them.
acid. Yes, ma'am. Yes,
Yes.
ma'am.
So when we apply acetic acid, so this coagulates. Okay. And that is the reason why when the protein coagulation happens, that is the reason it appears milky white or white.
Yes, ma'am.
So this is
What does
we have
what does India recommend as the primary screening test?
acetic acid, VIM.
Yeah, we do VIA.
Yes. Diagnostic workup and imaging. So how we go about with the diagnostic workup is first is the history, the examination, routine investigations,
Sorry,
imaging, and the
before
yes.
that, which is most sensitive and specific, VIA, Willy, or HPV based screening? Do you know? And
Uh,
why?
the most sensitive and the specific would be the HPV based screening of the patient.
Then why we do VIA? So what is the issue? What is the problem or
So
challenge
resource
with?
constraints are the resource constraint is one of the issues mainly
So
we
we are
adopt.
talking, yeah, so we are talking of a public health program which has to be reached out to women who are eligible for this screening. It is not just for a person who comes to your hospital, okay? So that you have to distinguish between a public health program versus a person, individual who's seeking the best way of screening. That you have to remember, distinguish between the two, okay? Because the challenges, the programmatic challenges, the logistics, all those things have to be taken into account, and also the cost when you're talking about a public health program. Okay? Carry on.
Yeah, I agree with sir. So always when we look at guidelines, screening guidelines, so there are two sets, one for resource constraint settings and one for ideal settings. Resource constraint
Yeah.
settings, it is VIA, and for ideal settings in which we have all the facilities, we would generally recommend co-testing, with HPV testing and pap smear.
Yeah.
Yes. So
Carry on.
in the examination and routine investigations, what we do is a general examination. Then we go ahead with a lymph nodal examination of the SCF and the inguinal lymph nodes, per speculum and bimanual examination, cystoscopy and rectosigmoidoscopy, routine CBC biochem, coagulation profiles, and urine examination. So in the imaging, why do we do a CCT abdomen pelvis? It is used to detect a primary tumor, nodal involvement, and distal mesh. Appearance on CT, the tumor might be enlarged, irregular, hypodense cervix, or a mass with ill-defined margins. Parametrial regions dense with involved uterosacral involvement or not. Nodes appear enlarged with more than 1 centimeters and axial dimensions considered as pathological. Now, accuracy in staging a CI cervix is 63% to 88%. The detection of lymph nodes is high with 77 to 85%. The sensitivity being 44% and the specificity being 93%. So this is a paper by Chameleon et al. Where the predictive value of CT in pre-surgical evaluation of primary carcinoma of the cervix. A total of 61 patients had
So listen,
preoperative.
you're
Yes,
talking of the fourth generation CT scan 1986. You can't even imagine the quality of CT scan of 1986 versus the CT scan that we do now. Okay, so that itself, radiology becomes obsolete. The imaging in every 10 years, that what we done. So, okay, so you just ignore it. I think today's ultrasound by a good sonologist would be better than the CT scan of done in 1980s. Okay, carry on next.
this
We will,
MRI abdominal pelvis.
yeah, that's yeah.
So
So you should tell us
is
the
used for the
value of
assessment of.
MRI, then we'll do the cervical one. You can go to the
So
next
in
slide, please.
Yeah, this is a T1 weighted images. Tumors are usually iso intense and normal cervical is hyper intense post contrast. Except extensive tumors on T1 are abnormal, irregular, and cervical margins can be prominently seen. Where the T2 images are mask of intermediate or high signal intensities. With and then the parametrial tumors are brighter regions on T2 images compared to
You should
its
always have images next to it. Just reading out plain text doesn't help. There should be image next to it. Next, go to the next slide.
These are papers by Postema et al. And this is imaging by what is the role of PET-CT when compared to
MRI,
CT?
what is the main feature? Which is the most important sequence for MRI? Without that sequence, you will not. This MRI has very little value. And what is the main additional information that you get from MRI?
So T2 images are the most uh, important set of T2 weighted images are the most important ones which we look for because it helps us to delineate.
You have not said that. And what is? Yeah. Okay. Carry on. Carry on. Move forward.
Yes.
No,
So
go to
this
the
is
next slide. So this you have said already.
so these are other imaging modalities in case there is involvement of yeah, there's parametrial involvement. You have HUN, you can use IVP, lymphangiography. Then you can go for chest X-rays, bone scans, and
You're talking of some of those obsolete investigations.
yes,
Okay,
sir.
IVP and lymphangiography. Okay, you can mention
Lymphangiography,
to say that these were earlier done, they
these
are
are
not being used now.
they are not being used. Yes.
Okay, move next. Move to the
So
next slide.
what are the diagnostic procedures which we use are one is a cold conization, the laser loop excision, diathermy excisions, then biopsies, punch biopsies are generally done on OPD basis. Multiple punch biopsies are taken from the suspected regions. It should be taken from all four quadrants of the cervix and the suspected areas of the vagina and must obtain a tissue from the periphery of the lesion with some adjoining normal tissue. Uh, this cold colonization will be explained by Dr. The cold colonization, there's no cross cervix. So, if there is an endocervical disease which cannot be appreciated on a colposcopy, it is better to go ahead with a cold colonization method where a cone of your cervical tissue with the endocervical region is taken and it can be used for your presence of diagnosis of microinvasive carcinoma post the biopsy.
What is the zone
So,
that we remove in cold conization?
Sir, ma'am,
What is that specific zone on the cervix
transformations,
that we remove in cold conization?
transformations. We,
Yeah.
we use
Why we remove the transformation zone? Why do we give so much importance to the transformation zone? Why do we remove it?
ma'am, this is the area where there's maximum changes which is occurring with age and and it is the most common site for CA cervix.
Yeah,
So
most
there's a German term for that. Do you know what zone it is called? See, if you're doing very well in exam, then you are asked these questions. What is a German term for this transformation zone, which was used in many textbooks? You don't know, carry on. Move on, move on. Oh, your slides have stopped? Your presentation? Hmm. See, today we have got two surgeons, so we will talk about the early stage cervical cancer management. Where are you? Dr. Subramaniam, just directly come to the
Good morning,
surgical
sir.
management, please.
Yes, sir. Yes.
I think staging we can do. All of you can read your staging. That's we don't have to do that. Just tell us the salient changes in the new FIGO. What is the
Sir, in stage 1A, the lateral extent of the disease, that is 7 mm, was removed, sir. The new staging of 1B3 was added, and the new nodal staging, that is 3C1 and 3C2, were added in FIGO 2018, sir, which were absent in 2009.
okay.
And like FIGO
Okay.
2018 also allows the use of imaging, that is CT scan, MRI, and PET scan, and surgical staging, that is by laparoscopic or open lymphadenectomy, is also recommended, sir.
Okay.
Sir, early
Any
stage
other
CS
major
cervix.
change, Sneha or Rohini or Prachi, there is in the staging? Any other major change that I'm not aware?
So that's what, sir. It used to be a clinical staging before. Now it can be either clinical, radiological, or
Yeah. So
pathological.
now it is.
Yeah.
Yeah.
Yes, sir. Early stage CS cervix includes the stages 1A,
Carry.
1B1, 1B2, and 2A disease. The goal of the management is to manage the patient with a single modality treatment. Careful patient selection plays a very important role. The treatment decision is influenced by tumor-related factors, patient-related factors, and patient's choice if available.
And you know, that's very important. A lot of people would, you very clearly said what includes early stage. Many people would put stage two all as early stage. You know, many cancers you say stage one and stage two is early stage. So stage 2B is very different from stage A. So that is an important point to emphasize. Those who are not doing gynec oncology or have less patients, they sometimes stage two, stage one, stage two. That's what general for all cancers, stage two. So here you are splitting clearly stage 2A and stage 2B. Okay.
So this is the management algorithm. We diagnose the patient after taking a biopsy, clinical evaluation, pelvic examination, and imaging is done. The disease is staged and early stage disease, that is FIGO stage 1 to stage 2A1. If there are suspicious nodes involved, we go for image guided FNAC or biopsy. And if the nodes are positive, then we treat the patient with concurrent chemoradiation. And if it is negative for metastasis, patient can go ahead with surgery. And in FIGO stage 2A onwards, concurrent chemo radiation is recommended. Treatment strategies that are available to us include surgery, radiotherapy, CTRT, and surgery followed by adjuvant radiotherapy or CTRT based on the risk stratification. Now, stage-wise management, stage 1A, which is diagnosed on cone biopsy, type A radical is recommended. Close is addressed if fertility is desired and cone margins are negative. Type B radical hysterectomy or radical trachelectomy plus pelvic lymph node lymphadenectomy is recommended if LBSI is present. And brachytherapy alone is recommended when the patient is not fit for surgery. In stage 2A disease that is diagnosed in cone biopsy, type B radical hysterectomy plus pelvic lymphadenectomy is recommended, or radical trachelectomy is recommended if patient desires to preserve fertility, and brachytherapy plus or minus EBRT is recommended. In stage 1B1, B1B2 and 2A1 disease, type C1, C2 radical hysterectomy plus pelvic lymphadenectomy, and radical trachelectomy plus pelvic lymphadenectomy for stages 1B1. That is, the lesion in maximum tumor dimension should be less than 2 centimeters, and radical radiotherapy, EPRT plus brachytherapy plus minus chemotherapy is recommended. Now the surgery, moving on to the surgery part, the modalities of surgery and concurrent chemoradiation are equally effective in treatment of early stage disease. If small volume disease, that is size less than or equal to 2 centimeters, and especially in young sexually active females, surgery is advantageous. The advantages include preservation of ovarian function and avoidance of radiation toxicities, mainly that is vaginal stenosis. Although controversies exist in the management of bulky tumors, that is size more than 4 centimeters, surgery is still a viable option, but should be done at high volume center with required expertise. The surgical options include conization, LEEP, that is loop electrosurgical excision procedure, and large loop excision of transition zone, and trachelectomy and hysterectomy. Starting with trachelectomy, in radical trachelectomy, the removal of entire cervix plus parametrial tissue plus upper 1 to 2 centimeters of vagina is recommended. That is similar to radical hysterectomy, but uterine corpus is spared to preserve fertility. And after that, the patient undergoes cerclage, which helps the patient in conception. The criteria for fertility conserving approach includes strong desire for fertility preservation, histopathology report of squamous or adenocarcinoma, FIGO stage less than or equal to 1B1 disease with preferable tumor size less than 2 centimeters, and there is no evidence of nodal or distant metastasis, and strong will for follow-up. Now, moving on to the types of hysterectomy, the first classification was given by Piver-Rutledge et al. In the year 1974. The type 1 is extrafacial hysterectomy, type 2 is modified radical hysterectomy. Here you need to note that removal of median half of the cardinal and uterosacral ligaments are advised. The uterine vessels are divided medially to the ureter at the point of crossing of ureter. So when you look at the type 3, that is classical Worthy Meeks operation, wide radical resection of the parametrium and paravaginal tissues are done with ligation of uterine vessels at the origin and ureter dissected completely to the bladder entry. And uterosacral ligaments are divided at cervical sacral attachment, and cardinal ligament is divided at the pelvic side wall. Now, this is the new classification, that is Quirlo-Moro classification given in the year 2008. It is of type A, B, C, and D. The salient points to note here are the type B. The type B classification is divided again into B1 and B2. B1 meaning without removal of paracervical lymph nodes. B2 is additional removal of paracervical lymph nodes. And C1, C2, they talk about the nerve preservation. C1 is with nerve preservation, and C2 is without nerve preservation. This is the image representing the Quirlo-Moro classification. Here, in this image, you can see that the red area is the vascular part, and the yellow golden color area is the neural part. So in type B1 disease, like this is the incision that is made. In type C1 disease, as you can see, the resection cut marks, the resection line is passing through the neural part, and it is the nerves are preserved. And in type C2, the nerves are sacrificed. The surgical modalities at large available.
Can I interrupt?
Yes, ma'am. Yes.
So, do you have any idea what nerves that we are trying, what are the nerves that we are trying to preserve and why we are trying to preserve them?
Ma'am, pudendal nerve and genital branch of femoral nerve.
No. In fact, these two nerves don't come in this plane at all. Okay, so we are trying to preserve the hypogastric nerves, which basically carry the sympathetic and the parasympathetic supply to the pelvic organs, that is the rectum, uterocervix, and the bladder. And the main reason that we are trying to preserve these nerves is because we want to prevent bladder dysfunction after surgery, which is the most common complication that can happen after a radical hysterectomy.
Yes.
Sneha, could you also add about trachelectomy and when you would be doing fertility preservation or not? Because our students earlier did have a lot of questions regarding this, in which patients we're doing trachelectomy. I don't think we've been following that in Tata, right?
Yeah. I think Dr. Rohini can also add this. We have not been doing trachelectomy procedures in TMH, though there are a few centers worldwide which do trachelectomy as a part of fertility sparing management of cervix, and they have published papers also. And the indication for trachelectomy is a tumor size less than 2 centimeters. And
yeah, Rohini here. So that's the main reason why we generally don't practice it in our center, because we have very rarely we have patients who fit into the criteria that a trachelectomy would have. Hello.
Yeah, we can hear you.
Yeah. So it first of all, the indications for trachelectomy are fewer, where the tumor size needs to be very small, the depth of invasion needs to be less than 10 mm, and along with that, we need to first do a cone and see that lymphovascular space invasion is not there. With these criteria met is when we can offer a patient a trachelectomy.
And that too, the patient has not already had a child and she
Yes,
wants
exactly. And to top it all, like sir pointed out, the patient should be desirous of fertility.
Yeah.
So, to our subgroup of patients who generally visit Tata do not fit into all these criteria, which is why trachelectomy being offered to patients is not seen very frequently in our center.
Thank you.
And adenocarcinoma, would that not be a contraindication? Like in the slide, I see adenocarcinoma less than 2 centimeters, if at all.
No, adenocarcinoma is not a contraindication as such for a trachelectomy. Fertility preservation if the patient is very motivated and desirous of fertility, and the rest of the criteria that I just mentioned fit in.
Yeah, trachelectomy itself has a simple trachelectomy and radical trachelectomy, just like how its hysterectomy counterparts are. So lymphovascular space invasion also per se is not a contraindication for trachelectomy. If LVSI is present, then we would additionally assess the lymph nodes also. So that is another separate procedure called as the Dargent's procedure, in which we would assess the lymph nodes and then go ahead with the main surgery. So,
okay.
Yeah.
Thank
Carry on with your slides for the other.
Role of sentinel lymph node biopsy. It is to avoid the extensive pelvic lymph node dissection without compromising oncological outcomes. Sentinel lymph node has detection rates of 89 to 92% and sensitivity of 89 to 90%. A role of sentinel lymph node biopsy, as in like whether we can just do sentinel lymph node biopsy and omit pelvic lymph node dissection, is not very well established. There are no randomized control trials comparing sentinel lymph node biopsy versus
Sorry, I would have to contradict in this statement.
Yes,
there are a lot of trials which have proven sentinel lymph node biopsy to be equivalent to complete pelvic lymphadenectomy in cervical cancer. Hello?
Yes, ma'am. Yes, ma'am.
Okay, have you included those trials in your future slides? So sorry if you have. Sorry for stopping.
No, ma'am. We have read about like the Cervical trials done in America, ma'am. Cervical 2 and Cervical 3.
So we have Cervical 1, 2, 3, Centirex, Centix, quite a few trials which have proven sentinel lymph node biopsy to be equally efficacious, and it is in the guidelines as well.
Yes, ma'am.
Yeah, and the thing is, the only caveat about sentinel lymph node biopsy procedure in any cancer, not just cervical cancer, is that we have to have our institutional experience and validate the procedure, in which the first few cases, about 20 to 30 cases, need to be done with pelvic lymph node biopsy to see our diagnostic performance of sentinel lymph node biopsy. So once we have validated it, which we are currently doing for endometrial cancer, sentinel lymph node biopsy is a proven efficacious procedure.
Yes, ma'am.
Sneha, would you agree with me?
Yeah, absolutely. Sentinel lymph node biopsy is recommended in the guidelines, even in the NCC and ESMO consensus for cervical cancer. These RCTs are mostly studies which are looking at diagnostic accuracy, but there are ongoing RCTs which are also looking into survival as their primary outcomes. So those results are yet to come. That is the Sentinel 3. Yeah.
Okay.
Moving on to minimally invasive surgeries, laparoscopic assisted radical vaginal hysterectomies, total laparoscopic radical hysterectomy, and robotic assisted radical hysterectomies are the options available. The advantages include shorter hospitalization time, lesser risk of blood loss, faster overall recovery time, better cosmetic results, and there is no difference in amount of margins obtained. And disadvantages include long learning curve, two-dimensional views with reduced depth of perception, and rigid instruments that are used. And moving on to the indications for post-op radiotherapy,
I'm
after
really
the
sorry to interrupt, because
Go
there is
back
a
to
yes,
the
very
previous.
important study, very important landmark study,
yes,
which came up in 2018, 2019 for the use of MIS in cervical cancer. And I think that is very important. Without discussion of that, thing is incomplete. It's incomplete. Yeah. Do you know that study? Yes, this one.
yes, LSCC trial, ma'am, laparoscopic approach to cervical cancer, phase 3 multicentric RCT. They included the FIGO 2018 staging, 2009 staging of 1A1, 1A2, and 1B1. The sample size was 631, and primary outcome that they were looking at was DFS, that is disease-free survival at 4.5 years. Laparoscopic or robotic assisted radical hysterectomy, that is minimally invasive surgery, the DFS was 86%, and abdominal radical hysterectomy, that is open surgery, the DFS was 96.5%. No? So the laparoscopic or robotic assisted radical hysterectomy arm, like it had higher rate of recurrence and lower OS. So this is still not established as the treatment of
No,
choice.
it
Like,
was established, then it got de-established. So all the
yeah,
guidelines changed, the recommendations completely after the study came out. It was a
So what
landmark
could be the
trial.
reason? What
Yeah.
could be the reason? Can you think what could be the reason for the results of the LACC study? Hello?
uh,
I can answer, but I think sir wants you
No,
to
no.
answer.
I want the student to answer. What is that
Yeah.
discussion in the community of gynec oncologists as to why we got these results? See, today we
not,
will just finish at the surgical part. We won't talk about post-operative radiotherapy. That we will discuss, next week. So let us. So what could have gone wrong? And it is quite a, almost 10% absolute difference.
yes, sir.
If you know, have you tried reading the paper, the discussion of the paper, or their commentaries and editorials on this?
Sir, maybe because of the steep learning curve and like like
Steep learning
surgeons
curve
in
or
high.
long learning? Anyway, I think one of the surgeons, our gynae surgeons, can explain to us as radiation oncologists.
Um,
Hello.
Yes,
yeah,
Sneha.
Rohini, you can
Go
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 on.
ahead,
I'll
Sneha. Go
answer.
ahead.
Okay. So this when we are insufflating the abdomen for minimal invasive surgery with carbon dioxide, it usually is a very high pressure atmosphere inside the closed abdominal cavity. So one of the theories was that exposure of this tumor into the abdominal cavity in this high pressure conditions would lead to dissemination or seeding of the cancer cells into the peritoneal cavity. So if you look at the details of this paper, there was a high rate of peritoneal recurrences also that happened in patients who underwent MIS. Rohini, would you want to add anything else?
Any procedure
Yeah.
related sort of contamination or spillage other than just pressure? Is that possible?
So other thing was uterine use of uterine manipulators during the procedure, sir. So there was use of uterine manipulators which might have caused disruption in the tumor environment, which could have also led to. So there are a few theories like this, and they are trying to come up with newer techniques where they are, I mean, all these problems can be solved with no use of uterine manipulators, and along with that, closure of the vagina before completion of the hysterectomy. So there are ongoing trials, otherwise robotic assisted, and there are some retrospective studies also. So it's currently we stand at a point where open surgery is the standard of care.
I think our institution, TMH, was one institution where we had, doubts about the safety of laparoscopic and this thing for cervical cancer, isn't it?
Not that I know of, sir, actually.
Okay. Not
Yeah.
So I think today's discussion, any surgical part is remaining, so we'll just cover that since we have the two surgeons here, and then rest of it we will cover next week.
So
So,
Yeah.
sorry, sir. Sorry.
About the Landoni's trial, how would you present and the critique of Landoni's trial? The critique.
Sir, 65% of patients in surgery arm received adjuvant RT, sir. So, because of that reason, like the morbidity was higher in the surgery arm compared to definitive CT RT arms, different RT arms.
So one thing is the morbidity. That means 2/3 of your patients are requiring both the modalities.
Bimodality therapy, yes, sir. Yes.
Is it because they were bad surgeons or they were bad selectors of cases? What is the reason?
Bad selection of cases, sir, and like the imaging modalities are not available for the optimal imaging modality was not available, sir. And so before
Which
like the
year
surgery.
were these? Which year were these patients recruited in this study? Do you know that? See, it all depends. The moment if you tell me it was like when you showed a study of CT scan 1986, I mean, I won't even look at that CT scan. So you have to know the years in which the
1990,
patients were recruited.
so 1997,
It was published, man.
published
Okay.
in 90, yeah, yes, sir, yes.
Okay, so that means the patients would have been recruited many 5 to 10 years before that.
Yes, sir.
One is the imaging. What else? Maybe Rohini or Sneha, one of you can tell, or Prachi, what are the critique or other things, critique of the Landoni's trial? Everyone loves to talk about it. What?
So, Prachi here. So patients were actually accrued in the late 1980s and no proper imaging modality. And as said, more than 2/3 of the patient in the surgery arm required radiation. So we do not have much clinical evaluations of patients.
So although it is a randomized trial, but it's a historical, basically, almost like we
Yes.
go back into the. Were they doing EUA before deciding the surgery? Was it done or not in these patients?
Not aware of that, sir.
Yeah, even I need to look at the
I don't-
details. Even I don't know for sure. Yeah.
Yeah, I mean, I don't think they have mentioned that an UA was done specifically prior to
I think the
recruitment.
last point, before we finish this thing. So, what is the utility of EUA in evaluating early stage cervical cancer before you take a decision for surgery or radiotherapy, whatever else? So, one of the students, Subramaniam, you or anyone else? Is there any role for EUA, or now that you have MRI and everything else, there's zero role for EUA, evaluation under anesthesia?
No,
So
sir,
once
MRI.
Let the student say
carry
then.
on. Yeah, carry on. That's what I was going to say, sir. Once the students answers, I would like to take this.
Yeah.
Sir, MRI plus EUA will be the gold standard, sir. Like
Sorry,
in
say that
EUA,
again.
sir, MRI plus the evaluation under anesthesia, both combined together, we'll get to know the better, the extent of the disease.
So that means
So it
for
will be
every patient, how many patients you do EUA here? How many patients before you take a decision about surgery or radiotherapy or combined modality?
so not many patients, sir. Like
So which are the
surgeon is not
patients where it will have the maximum value addition? Okay. So which are the patients where it will have the maximum value addition? And if you do not do EUA, you are more likely to be in that sort of Landonese situation.
micro-invasive disease.
Microinvasive disease.
LVS.
Anyway, I think it's beyond their expertise, so one of the surgeons can probably tell.
I'll take this one, sir. We
Yeah.
actually looked into a
Yes.
retrospective data of our own institute for
Yeah.
MRI and histopathological correlation. So what we found was MRI did overestimate the presence of parametric invasion in a few cases, which on EUA were turned out to be negative for parametric invasion, and that correlated well with histopathology. These were few cases, but this did happen. So when we have a clinical rate, we do go ahead with EUAs.
So there's discordance between the clinical and this thing. That's very important.
Yeah.
And in some patients, because of pain or some discomfort, you can't do a clinical evaluation proper.
Right.
Criteria or some anatomical reasons. So.
Okay. Right. Yes, I would agree with that. So, from surgical point of view, the other things that students should know is our NACT surgery versus chemoradiation trial, the TMH1 and the URTC1. Yes. And other than that, the role of debulking and staging surgery with respect to nodal disease. So these are the two other areas where surgery and of course palliative surgeries for palliative and exenterative surgeries.
Right.
Yes.
So Subramaniam, do you know about those NACT surgery after neoadjuvant treatment? The trial, the findings? No? Or you all have kept it under locally advanced?
Yes, sir. Yes, sir.
Okay. So they are limiting up to stage 2A here. Okay. So
that did include stage 1B and 2A and 2B disease. So I mean, if a question has been asked in the exam regarding early stage, maybe they can write a few points about that.
Yes. I think they'll be presenting that study.
Okay. Yes, sir.
Okay. Thank you very much. We took more time, but these are very important points, and both you, Rohini and Sneha, your points were very well, taken. We got some clarity, the students, and thank you very much. So we'll continue with early stage cervical cancer next week. Again, that will be more focused on radiotherapy and post-operative radiotherapy, and also after NACT, and including details of radiotherapy and brachytherapy. And so your students, gynae oncology student, for them to understand radiotherapy, if they want to attend, this will be on YouTube also. Later on, they can understand the nuances of radiotherapy, because they also need to know that. And then we will have locally advanced.
Thank you so much. Thank you, sir. Thank you, sir. It was a very good discussion. Thank you, sir.
Thank you. Bye-bye.
Thank you, sir.